try to get through this smartly. I was asked to talk about the complications of high tibial osteotomy. Something wrong with the microphone. Maybe that happens at 12 o'clock. The microphone closes.
Maybe you can use this.
Can you hear me now? Okay, so this is a good article, September 2010, British Journal. They looked at 104 patients with closing wedge, 93 patients with opening wedge. What they found, there was no difference in outcome as far as patients were concerned, and no difference in complication rate. But the significant thing is an independent risk factor for complication is obesity. And this is something that you have to be aware of when you're planning high tibial osteotomy. The obese patient does not do well. If we look at this paper from knee surgery in 2008, randomized trial of closing versus opening wedge in 40 patients, what they found was that the closing wedge osteotomy not only had increased patient satisfaction, but also had a decreased complication rate compared to the opening wedge group. That's because of delayed union in the opening wedge patients. Now, this is a small number of patients, only 20 in each group, and we know that in larger series, the complication rate tends to be the same in both groups of patients. The complications are different, but the complication rate is the same. So complications can be, of course, early and late. Slide, please. The early complications are nerve injury, vessel, either injury or thrombosis, surgical infection, inadvertent joint injury, and avascular necrosis of the proximal tibial fragment. Late complications in closing wedge osteotomy are non- and delayed union, undercorrection, which is the commonest, most significant complication for these patients, and of course arthritis progression, which is a natural consequence of the disease process. Now, nerve injury, most commonly in closing wedge osteotomy, is the peroneal nerve, and posterior tibial nerve is rarely injured in this operation. This paper actually looks at drop foot after lateral closing wedge osteotomy. It's quite a complicated paper. Their meta-analysis of the literature suggested an approximate incidence of 2.5% of this complication, which is a high incidence. Fortunately, most of these are neuropraxias and recover. What they found was that tourniquet use is related to peroneal nerve palsy. The longer the tourniquet time, the more likely there is to be a peroneal nerve palsy. And also, they found the incidence was significantly higher with proximal fibular osteotomy. And these authors have suggested that a more distal fibular osteotomy is appropriate if you want to minimize the chances of this particular complication. Now, vessel injuries are rare with either opening or closing wedge osteotomy. They do occur, but of course they are very infrequent. What is common, however, is deep vein thrombosis. Turner in the JBJS in 1993 looked at deep vein thrombosis after high tibial osteotomy and found a venographic incidence of 41% without prophylaxis. So that's the same incidence as we would see with total knee replacement. So prophylaxis similar to total knee replacement should be utilized in patients with closing wedge high tibial osteotomy. Infection, we all know about that, wound healing delay, bone healing delay, and chronic infection. All these patients should be treated similar to total joint replacement patients and should receive prophylactic antibiotics on the day of their surgery. Joint injury can occur, either a ligament injury on the medial side in doing the medial wedge, opening wedge, joint penetration by fixation, or inadvertent joint fracture. Looking at cortical fractures, this paper from Acta Orthopedica looked at 44 closing wedge, 43 opening wedge osteotomies, the incidence of cortical fracture during the procedure. They found that the cortical fractures were much more common with closing wedge osteotomies. In other words, a fracture of the medial cortex occurs very frequently with closing wedge osteotomies. And those of us who do that operation know the reason for that is we're trying to keep a little hinge intact on the medial side to maintain stability. So these are much more common than in opening wedge. The interesting thing, however, is that even with the cortical fractures and the lateral closing wedge osteotomy, there was no significant loss of correction in those patients, whereas in patients with opening wedge osteotomy with inadvertent medial cortical or lateral cortical fracture, there is a significant loss of correction in those patients. Avascular necrosis occurs as a consequence of a too small proximal fragment doing the osteotomy too proximal, excessive joint sclerosis, and in our research, in our paper which we published some years ago, we found the use of a blade plate versus staples or screws significantly increased the incidence of avascular necrosis. Now this one's not working. Is this one working? So this shows an avascularity of the lateral fragment with collapse. Non and delayed union is more common in the medial opening than the closing lateral, but it does occur in the closing lateral wedge because of poor apposition of bone surfaces, undercorrection, inadequate fixation, and of course, once it occurs, it's very difficult to treat. This shows an example of a delayed or non-union following closing wedge osteotomy, and you see it's going to be difficult to get that small proximal fragment soundly fixed in order to heal. Undercorrection is the number one reason for failure after closing wedge osteotomy. There are many causes for undercorrection. Delayed union is one. Surgical error is probably the most common. Poor fixation, poor bone quality, and obesity are all factors.
Thank you.
We're on our third microphone now. I promise I'll finish. These guys are going to get me out of here no matter what. Undercorrection, of course, results in a difficult revision to total knee replacement, and it's the number one cause for failure, early failure of high tibial osteotomy. So here's a man with bilateral significant varus deformity. Here's the same patient 1 year later after a closing wedge high tibial osteotomy, and you can see his two knees look identical, only the sclerotic line shows that he's had an osteotomy, and the undercorrection in this case has led to early failure of the operation. Arthritis progression is the natural history of osteoarthritis, but it's made worse by undercorrection, by residual knee stiffness, and by patella baja. If we look at this series of papers from the British Journal, this series of patients, they had 132 patients with a 16-year follow-up. These are all closing wedge osteotomies. And you can see the survivorship here is very similar to what was presented earlier today in terms of survivorship for opening wedge osteotomies. What they found was that at 15 years, with total knee replacement being the end point, 90% of patients still had not had to undergo knee replacement surgery. The failure rate in these patients was related again to an elevated BMI. Remember, these are Japanese patients. A BMI of 27 would be a dream for most of us working in North America. But these patients are heavy by Japanese standards. And, of course, a decreased range of motion prior to surgery, and other speakers this morning have referenced this, that if they have a stiff knee prior to the osteotomy, the results are not good. In this article from Acta Orthopedica, they found the complication rate and the failure rate was related to female gender, arthritis severity, and increasing patient age. So all of these factors increase the risk for failure at 10 years. None of these are within your control as a surgeon, except as it relates to patient selection. So the avoidance of complications, number one, patient selection. Number two, pick the type of osteotomy that's best for the particular patient you're treating. Thirdly, it must be done in a technically excellent fashion. Every speaker this morning has emphasized the importance of technically excellent surgery in achieving a satisfactory outcome. Next, you need good postoperative management of these patients in terms of physical therapy, range of motion, muscle strengthening, and weight bearing. And finally, the early recognition and prompt treatment of any complications that do occur will minimize their long-term effect on your patient. Thank you.
One question, please. Yes, just one.
I have heard that in UK, because you do